Top Bed Talk.
Hello, I'm Bobbi Jean Sweitzer, Systems Director for Perioperative Medicine at Inova Health Systems, and I'm delighted to be here with you today to present Anemia Clinic How-To. I think this is a very important statement. Choosing Wisely is an initiative of the American Board of Internal Medicine, started about 10 years ago, and it's to advertise important aspects of medicine that they want to advertise to both patients as well as clinicians. And they ask every subspecialty society in the United States to give them 5 recommendations. You can see for the Society for the Advancement of Blood Management, their number 1 recommendation was to not proceed with elective surgery in patients with properly diagnosed and correctable anemia until the anemia has been appropriately treated. I think this really sets the stage for what I'm going to talk about today. This was a press release just a month or so ago that highlighted the incredible blood shortage that we have in the United States. This has been going on and building up throughout the past year with the pandemic. This is due to both an unprecedented actual overuse or excessive use of blood and also a significantly decreased donations. And so the Red Cross, which typically has about a 5-day supply of all types of blood, at that time only had about a half-day supply of type O, which is the emergency release blood that we're all familiar with. And the majority of blood centers had only 1 day or less of blood supply. Anemia is quite common in our surgical patients. In fact, it's estimated that maybe up to 3/4 of patients having surgeries are anemic. But even for elective, reasonably healthy patients, anemia is quite common. Other times it's previously undiagnosed in our population. Anemia is associated with decreased survival, both long-term as well as perioperatively. There's higher rates of hospitalizations, and it's one of the strongest predictors of perioperative transfusions. In fact, about a half of all blood that's transfused is given to surgical patients. These slides represent the morbidity and mortality associated with anemia. Across the x-axis, you will see various comorbidities, cancer, even advanced age, renal disease. And you can see on the left side, morbidity is increased, and on the right side, mortality is increased with comorbid conditions. Not a surprise to this audience. But when you factor on anemia on top of that, that is represented by those blue columns. So you can see almost across the board, the risks are either doubled or tripled if one has anemia concomitantly with one of those comorbid conditions. It's also very expensive to give blood. It's estimated that 20 to 30 million units of blood components are transfused in the United States alone every year. And as I mentioned before, about half of that is given perioperatively. It costs on average $1,000 or more to give a unit of red blood cells. And that's not even counting the testing, the type and screening and cross-matching that goes on beforehand. Many hospitals spend upwards of $5 million a year, US dollars, to transfuse, to maintain a blood component in their blood bank. And most hospitals lose money on blood products because it's actually poorly reimbursed. There's a significant financial burden and patient burden. There's material costs, personnel costs. Patients are often have prolonged ICU care and ventilator dependency and prolonged lengths of stay when they receive blood. So transfusion of blood products is really not the answer to anemia. So I'm going to focus primarily on iron deficiency anemia because this is a relatively easily diagnosed and treatable type of anemia. So iron deficiency anemia is best defined by a ferritin level. And a ferritin level of less than 30 mics per liter absolutely defines iron deficiency anemia. But however, with inflammation, ferritins can be elevated. And so in that setting, most people, everybody agrees that a ferritin level of less than 100 mics per liter is diagnostic. And many people believe we should change the cutoff for all patients to be defining iron deficiency anemia with a ferritin level of less than 100 mics per liter. However, because ferritin is an acute phase reactant and it does falsely elevate in settings of inflammation, chronic conditions such as cancer or heart failure, then the second best test to look at iron deficiency anemia is the transferrin saturation. Transferrin is the protein that carries iron through the blood into end organs. And if you have a decreased saturation of transferrin of less than 20%, that is diagnostic for iron deficiency anemia. So again, the first test to look at would be ferritin, but if it's elevated, then you can look at the second best test, which is the transferrin saturation. So even if your ferritin level is high, but your transferrin saturation is less than 20%, those patients will respond to iron. Another test that's not always available in everyone's institution is the reticulocyte hemoglobin equivalent. Reticulocytes are those brand new red blood cells that are produced, and this test is looking at the amount of hemoglobin in those new red blood cells. And that's the first thing the body does to conserve blood making is it still makes red blood cells, but they're just microcytic and hypochromic and don't carry very much hemoglobin. And that test can be run off the same purple top tube as the CBC. So if you have that available in an institution, you can use that in place of the ferritin and the TSAT levels. This graph just demonstrates absolute iron deficiency anemia. But then there's patients who we believe have functional iron deficiency, and that's represented by the light gray and darker gray columns there. And those patients will often not respond to oral iron, but they will respond to IV iron and or IV iron plus erythrocyte stimulating agents. The only patients who should not be receiving iron are those represented in that black area. Those patients who have very high ferritin levels of greater than 800 or TSAT levels of greater than 50% represent patients who have sufficient, if not iron overload. And so those patients are not going to benefit from additional iron therapy. So the first step in setting up treatment of iron deficiency anemia is diagnosing iron deficiency anemia. We went over a few of those tests, but typically the way anemia is often diagnosed in the preoperative setting is as a patient is seen, the patient has a CBC, the patient is recognized to have anemia or low hemoglobin, and then the patient actually has to return for additional testing of the ferritin and the transferrin saturation because they're run off of different types of tubes. And so that by itself inconveniences patients and this delays diagnosis of treatment. So I published this paper in Anesthesiology last year describing an expedited deficient process for diagnosing iron deficiency anemia with just one visit or one setting to both save time and also not to inconvenience patients. And so again, as I described, traditionally, one draws a purple top tube, the patient's discovered to be anemic, and then they have to come back for further testing. This process I described in the anesthesiology paper we called it the pre-procedure anemia evaluation. And at the time the patient's initially seen, we draw 2 tubes of blood. We draw both a purple top tube and a green top tube. Purple top tube runs the CBC. If the patient's discovered to be anemic, then the lab automatically reflexes to do additional testing off of the green top tube. We actually draw both of these tubes. We send them down to the lab. The lab just holds that green top tube. There's only one order that has to be placed though. And automatically, if the hemoglobin is less than 12, it reflexes to the additional tests. This just saves time and money because the patients won't have those additional tests run if they don't need them. But if they need them, then we have the tube ready for us. If the patient's not anemic, then that green top tube is just discarded. The tube itself costs like 12 cents, I believe, is what we calculated. And there's 3 cc's of blood in there. So that's simply all you're wasting. If you are going to evaluate for the anemia itself, we do encourage you to do, in addition to the iron studies, do a creatinine, a B12 level, and a TSH level. Because hypothyroidism and chronic kidney disease are 2 very common conditions associated with iron deficiency anemia, and those need treated in different ways than just simply iron deficiency anemia. And then it's quite rare to have B12 deficiency, at least in developed countries, but it does occur, and it's also easily treated, and it can occur concomitantly with iron deficiency. So we do recommend that if you're going to do that, you just go ahead. We also recommend a reticulocyte count because if you get a basic reticulocyte count or a baseline reticulocyte count, then you can use that to measure the response to your therapy later. So when is it important to use IV iron rather than oral iron? Well, I first want to say that oral iron is incredibly poorly absorbed, and it takes typically months to years to restore iron levels with just oral iron itself. Most patients will not tolerate oral iron long enough or well enough to stick with that program. It can cause some GI upset and constipation. So they usually stop taking their iron well before they are treated. So I think it's important to utilize IV iron when you want to rapidly restore iron stores, which is almost always the situation preoperatively. And also when there's high iron requirements, because you can give just so much more IV iron than one will ever be able to give patients orally, or even if they take it, they will not absorb it. So in patients who have chronic or uncorrectable or, heavy bleeding, where you're not really keeping up with the blood loss, by simply taking IV PO iron, please consider the IV iron. Patients who are on chronic hemodialysis benefit. Patients who have malabsorption syndromes, as you can imagine, if you're not absorbing iron well in a healthy gut, you're not going to absorb it. If you have celiac disease, atrophic gastritis, you've had gastric bypass. In fact, about 50% of patients who have had weight reduction surgery are iron deficient and have iron deficiency anemia. Patients with inflammatory bowel disease have very ineffective erythropoiesis. They have poor absorption and intolerance, and they have a functionally low erythropoietin. And patients who are unwilling to receive transfusions, when you want to particularly raise their hemoglobins to sort of super high levels, will typically require IV iron and even ESA to achieve that. And those who obviously are intolerant or non-compliant with oral therapy. So the key question is, how much iron do I give? Well, it's pretty simple to do. You just sort of use this formula. It's called the Deficiency formula. It's been in the publications for some time. You just Google it. It's based on the patient's starting hemoglobin, your desired hemoglobin, the patient's weight, and it is important to use ideal body weight, not total body weight. And then you use a factor of 2.4, and then you add a little extra iron to restore the iron stores, because the body's really smart, as I mentioned earlier, and it uses up all of your iron to continue trying to make red blood cells before the patient even becomes anemic. So you do need to give a little additional iron. The Deficiency formula says to give additional 500 milligrams. Some formulas and some evidence seem to suggest you need to give up to 1,000 milligrams. You can round up to the nearest 100 for dosages. And frankly, most studies support that most patients who have iron deficiency anemia will benefit from 1,500 milligrams of iron. So if you don't want to waste your time looking the formula up or calculating all of this information, you can just target a replacement dose of 1,500 milligrams of iron. This slide demonstrates some various intravenous iron formulations that are at least available in the United States. There may be others available in other countries, or there may be some restrictions. But I believe right now we have 5 of these formulations. So, you will need to check with your pharmacy to see what you have on formulary, or work with your pharmacy to get 1 or 2 of these formulations available. I'm going to talk about 2 specifically, and those 2 that I've had the most experience with, and one of them is probably the most commonly used compound around the world. And that's iron sucrose. So iron sucrose was one of the early IV iron preparations after the high molecular weight compounds, which are no longer being used, at least in most first world countries, because of the high rate of anaphylaxis or allergic reactions. The newer low molecular weight compounds, such as iron sucrose, have a very, very low rate of allergic reactions. The typical dose of iron sucrose is 100 to 300 milligrams, either daily or every other day. You'll see some different recommendations. Some are every other day, but many people believe you can give it every day, or at least 3 times per week. Typically, this requires 4 to 5 infusions, as you can do the calculation yourself, to achieve that 1,500 milligrams. Overall, it's cheaper per unit dose. However, it's a higher personnel cost because you're giving smaller incremental doses. If for inpatients, this is not a big deal. The patient's already there. They have an IV. The nurse just has to hang it. But if you have an outpatient anemia clinic and you're having patients come back for appointments, this is very inconvenient for patients, and it requires an additional appointment each time. So it also, though, is probably your best return on investment for Medicare and Medicaid patients. Though more recently, I have been able to get a fair number of Medicaid patients a different preparation that I'm going to talk about next, which is much more convenient. And that is ferric carboxymaltose. This has potential advantages in that it releases iron more slowly to transferrin, and then which is then delivered to the bone marrow, so that it doesn't get delivered in non-bone marrow sites, such as the liver and the heart. You can give a large dose administration. You can give either 750 milligrams, which has been the standard dose at one time, or there was recently approved the use of 1,000 milligrams in one dose. The total iron requirement, obviously here can be achieved with just 1 to 2 infusions. They're typically given 1 week apart. It is a higher unit cost compared to iron sucrose. However, if you factor in the lower personnel costs, fewer patient visits, it is much more favorable to outpatients. There's also improved patient compliance with this because if they only have to come back for 1 or 2 visits, they typically stick with the program as opposed to having to return for up to 5 visits. It also shortens the time to your rise in hemoglobin because you give it a much larger dose up front. And sometimes for many patients, you only have a week or so lead time preoperatively. So therefore, ferric carboxymaltose is particularly advantageous in that setting. So another agent that I think you should become familiar with and be comfortable using is erythropoietin stimulating agents. Erythropoietin is produced and secreted by the kidneys. So patients with chronic kidney disease have an absolute deficiency of this. This induces red cell production. So iron is kind of like your gasoline and erythropoietin is like your engine or starter. You need both of those to produce red blood cells. So if the patient is not producing erythropoietin themselves, you must supplement that. So we mentioned about the absolute deficiency in chronic kidney disease. Patients on dialysis typically receive this agent on a regular basis. But those who have a chronic kidney disease before they are on dialysis are often overlooked. It's also inappropriately low or functionally low in patients with GI cancer and inflammatory bowel disease. Those patients also particularly benefit from these agents. There's also a decreased response of the bone marrow to erythropoietin in patients with chronic diseases such as any inflammatory disease like cancer or heart failure or rheumatoid arthritis. So those patients also will often benefit. And in fact, those conditions that I just mentioned are unique indications for giving ESA agents. So ESA is approved for reduction of RBC transfusions in surgical patients. It's indicated for preoperative hemoglobins of less than 13 grams per deciliter in those at high risk for perioperative blood loss and in those who refuse transfusions. In fact, the ASA practice guidelines on perioperative blood management specifically say pre-admission treatment of anemia includes the administration of erythropoietin and or iron to improve preoperative hemoglobin levels. I would change that to say, if you're going to give erythropoietin, you should absolutely be giving iron in most patients because you need both of those for the production of red blood cells. So there have been some concerns about ESA. I think these are somewhat concerns of the past. I would say that more recent data shows that these agents are incredibly safe for most patients. But some tumors do have EPO receptors, but there was a meta-analysis of about 60 studies and it showed no effect on mortality or disease progression. So at least for patients who have non-hematologic malignancies, I believe there's no concern currently about getting EPO. There's also was a concern about venous thromboembolism. There does seem to be a slightly increased risk of VTE in patients. However, if patients have a very, very low risk of VTE to begin with, then that increase in risk also remains very low. But I do believe, you should use it with caution in certain patients with malignancy or with recent VTE. So one way around this is to use lower doses. We'll go over those in a minute. Or consider thromboprophylaxis in high-risk patients, or if you're particularly concerned, engage your hematologist to help you. But I routinely have given ESA in patients with malignancies and with histories of remote and not active VTEs without a problem. So the dosing is 300 to 600 units per kilogram subcutaneously weekly, typically for 4 doses, if you can do that. It is important to monitor your hemoglobin levels. If after a full month of therapy, the response or hemoglobin has been less than 1 gram per deciliter, you should increase that dose. If the hemoglobin, though, rises too quickly, meaning it rises greater than 1 gram per deciliter in 2 weeks, then you should decrease your dose by about 25%. You should discontinue ESA if your hemoglobin fails to rise at least 1 gram per deciliter after a 2-month period. I'd remind everybody that CMS will not pay for ESA if the hemoglobin is greater than 12 grams per deciliter. You can appeal. I'll talk about that in a little bit, but typically that is a cutoff. So let's talk a little bit about the actual staffing of the anemia clinic. I've talked about how you diagnose anemia, how you treat anemia. So I don't think you have to have any additional staff to diagnose or write orders for anemia if you partner with your preoperative providers. in your preoperative clinic with your PCPs, with your surgeons, because they can be ordering these laboratory tests and you can make it easy for them to even order the IV iron therapies. However, if you're working, have APPs or physicians in a preoperative clinic, it's relatively easy and simple for them to just order these tests and the IV infusions. They absolutely should be doing that for patients they're seeing. They can even partner with some of the patients who are not actually being seen to take on this additional role with a little extra time. So, again, other providers who have access to your EMR who can fax in orders for iron and EPO and schedule anemia clinics, clinic appointments quite easily, or at least that's the way you should set it up. Or they can simply refer patients to an anemia clinic where, perhaps you set up a part-time APP who would evaluate patients and do everything from ordering the initial testing to, ordering the infusions and monitoring that, or any step along the way that's convenient. So I don't think it's one size fits all. I think you should look at what the resources that you have already and try to utilize those resources so that you don't have added costs from the get-go. So, also like using such as your pre-op clinic or hospital call centers to schedule appointments. You don't have to have a whole nother appointment scheduling system for your anemia clinic. For the iron infusions itself, I think you can staff that with just one RN working typical shifts. That RN should be able to manage at least 2 patients per hour. If you find yourself very busy and you have more patients than that, then you can staff more RNs. We typically recommend a staggered appointment every 30 minutes because even though the patient's there for every hour, much of that is just watching, observing the patient. I'll get to that in a little bit. So the equipment you'll need to consider having is a computer so that you can do documentation and ordering. If you create a nice template for your EMR, that will make it easy for people to document what they need to do and support your billing. You want to have some comfy chairs for the patients to sit in because they need to be in your clinic for about 45 minutes to an hour. You need a portable monitor that allows you to measure blood pressure, pulse, oxygen saturation, and a temperature monitor. You do not need to monitor ECGs or continuous ECGs. You need an infusion pump to be able to hang the drug. You need some intravenous catheters. Perhaps you want a vein finder or an ultrasound because some of these patients can be quite challenging. They often do have cancer. They're chronic kidney disease patients on dialysis, so they may have limited access. If the patient has a port, I really encourage people to be familiar and train your nurses to access those ports because they're quite convenient. Obviously, everything you need to have an IV, right? IV catheters, intravenous tubing, gloves, disinfectant, Band-Aids, etc. You need to have the iron preparation, the actual IV iron itself. And so you need to partner with your pharmacy. These things are typically reconstituted. They do not need special storage, but they typically are, once they're reconstituted, just effective for about 24 hours. So, they can be delivered to your clinic the morning of or even the night before for patients. They're relatively expensive, or at least ferric carboxy maltosase, as I mentioned. So you want to make sure you have a good understanding with your patients that they show up for their clinic appointments and they do not, miss those. I actually have had incredibly good success with patients actually showing up for these appointments. I rarely had any no-shows or cancellations at the last minute. We rarely had to discard any unused iron. The EPO is a little bit easier to use. Again, you, of course, get it from the pharmacy, but that's something you could stock in your own anemia clinic. It can be also delivered with your IV iron preparations. Again, I showed you the dosages, so these are typically prepared. You do want to typically round up those doses to any 10,000 unit dose because that is just the way it's typically prepared. But it comes in like 10,000, 20,000, I think 30 or 40,000, so you can mix and match the different ones. It's a simple subcutaneous injection. It's maybe nice to have a few other kind of, drugs on hand, such as acetaminophen, because some patients will spike a bit of a temperature with these infusions, or diphenhydramine, because patients can get a little bit of itching, local anesthetics to start your IV. So I would say that those are not absolutely necessary. The patients can just take those when they leave. You do need those emergency equipment and drugs. Again, I mentioned that the early preparations of IV iron were associated with a fairly high risk of allergic reactions and even anaphylaxis. The newer preparations are incredibly better tolerated. In fact, in the previous institution I was at, we infused, I think, close to 5,000 individual iron infusions over about a 4-year period, and we had no allergic reactions and no anaphylaxis during that time. But you do want to pay attention to the need for emergency equipment and drugs. So to the typical visit, the patient checks in for the appointment. They have a set of vital signs as noted here, both once pre-infusion, once post-infusion, the IV gets started. I encourage you to hang a bag of crystalloid and piggyback your IV iron into that crystalloid, because IV iron is black or very dark. And if it does infiltrate, it can cause permanent staining of the skin. So you do want to be assured that your IV is intravascular. You do not want to infiltrate IV iron. The iron is administered via the infusion pump. Again, it can be administered anywhere from about 15 to 30 minute period. You just give the EPO subcutaneously, as I mentioned already, and then we typically recommend you monitor the patient for about 15 minutes post-infusion, much like after your COVID vaccine, to just be sure the patient doesn't have any significant reactions. So this just demonstrates the slide that shows the amount of iron infusions that we gave at my previous institution from the time that I set up this clinic in January of 2017 up until March of 2020. You can see that we gave a substantial number of infusions. So it's important to get paid for what you do. So again, insurance will typically cover IV iron when oral treatment has failed to be effective. So the first thing you should do when you have a patient that you suspect with IV iron is encourage them to go out and buy some oral iron. You can buy that over the counter, start taking it. And failure means that the patient either doesn't have a rising hemoglobin or doesn't tolerate it. And there's no recommendation of how long you have to wait to see that the patient doesn't have a rise in hemoglobin. So you could theoretically just have them start taking the oral iron. And if surgery's in a few days, they're not going to have a response to that. So they've effectively failed. But there's also other indications for using IV iron and insurance will cover. When patients are intolerant of it, so they say they won't take it, it causes constipation or you're upset. When patients refuse blood products, when patients have chronic kidney disease, and preoperatively in the preoperative setting. And this is where this is so important for this audience, because we're typically dealing with patients preoperatively. You can consider pre-authorization. However, you may find that, your insurance companies, if you're doing good documentation, will routinely cover this. And pre-authorization can often take, up to 2 or 3 days. Sometimes even longer than that if you haven't filled out all the paperwork correctly and the insurance company first denies it. So many institutions have decided that they're just going to go ahead and offer this, because if you look at the whole cost of not treating anemia in the perioperative period, there's higher costs associated with giving blood and the complications of anemia than what you would lose on giving patients a few IV iron treatments. So if you don't have enough time, if surgery cannot be delayed safely, then I would consider, you should partner with your institution to be able to give some of these patients IV iron and erythropoietin without pre-authorization. I do reminded you that CMS will not pay for stimulating agents if the hemoglobin is too high, and other insurance plans and CMS have very specific criteria. So a good thing to do is to partner with your authorization team. Get a list of those criteria so from the get-go the criteria that are required, so you can include those diagnoses and ICD-10 codes from the very beginning when you are asking patients to get iron. I also encourage you to build these into your order sets so that people need to answer those questions from the get-go. That really saves time. Do be prepared to advocate on behalf of your patients. Yesterday, I spent about 30 minutes on the phone with Humana Health answering some questions for a patient of mine who needed to get erythropoietin stimulating agents. The pre-auth team had already spent many more hours than that in several days. And I personally had spent many more hours and over several days writing different orders and doing different things and, kept getting these denials. So finally, I needed just to pick up the phone and do an appeal myself. So it can be a bit painful, but can be very effective. It's also a great learning experience, because in the process of doing this, you will learn exactly what you need to do ahead of time with your team to be sure that these appeals don't get denied from the get-go. And then you will be incredibly educated around all of the nuances and all of the diagnosis codes that you can use to cover payments. So just remember that whenever you do diagnose iron deficiency anemia, you have to realize that there's a cause for that. So some patients, it's obvious they have a GI bleed. They have colon cancer. They have, dysfunctional uterine bleeding. But for many patients, they do not have an obvious source of blood loss. And the only two reasons why people have iron deficiency anemia True absolute iron deficiency anemia is inadequate intake of iron or absorption of iron, or they are losing iron. They can have functional iron deficiency from some of those other reasons that I mentioned earlier. But it's important that if it's an absolute deficiency of iron, that you partner with their primary care physicians or other providers to be sure patients not only get treated for their IV iron, their iron deficiency or their iron deficiency anemia, but then they have further evaluation, follow-up to diagnose these other medical conditions. There's a fairly high rate of cancer in elderly patients that sometimes is only first discovered by the presence of iron deficiency anemia. So I do encourage you to realize that you don't just want to put a Band-Aid on this problem, and which is the first goal is to treat the iron deficiency anemia preoperatively to better prepare the patient, decrease risks and complications of surgery, and lower costs and avoid transfusions. But also for long-term care, be sure these patients are plugged in for the right treatments. So in summary, I think, you can identify patients with anemia and the specific type of anemia relatively easily. The most important ones is the iron deficiency and B12 deficiency, because those are readily, easily treated. But also, these associated conditions such as chronic kidney disease and inflammation to guide your therapy. So if it's simply iron deficiency anemia, intravenous iron is, I believe, the most effective and efficient treatment. If it's B12 deficiency, then obviously B12 injections or oral B12. And for those patients who will benefit from erythrocyte stimulating agents, that's an important component to offer in your anemia clinic. Thank you so much. Bye-bye.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.